Thank you for your time, Mayowa. Tell us about your pioneering work on low-cost neurorehabilitation in Africa, and how you did it, and where things are now, and what the future holds.
Okay, thank you very much. Well, we did it because there was no option. Africa, particularly sub-Saharan Africa, more than 400 million people live with less than $1.5 a day. And that's really very appalling. So, and not only that, in spite of the fact that they have little resources, we're also facing a very huge burden of communicable diseases as well as non-communicable diseases, of which stroke is a leading part. And of course, we know that stroke usually results in disability. So we are really overwhelmed by a large number of stroke patients and of other people with neurological disabilities that require this service, and they have little or nothing to pay for it. And in fact, by the time they come for neurorehabilitation, they have exhausted their resources on acute care, yes, neuroimaging, blood works, and all of that. So we really had no choice than to find ways of making sure that we are able to help this teamy, large number of people who are otherwise helpless and hopeless, to still make sure they can achieve something in life, they can fulfill their purposes and dreams, they can have a good quality of life. So now, what are the principles that we've implemented to achieve this? The first one is, of course, for neurorehabilitation or anything at all, is making sure there is an accurate diagnosis, because that is what is going to determine the treatment. So if the diagnosis is right from day one, then the resources will be deployed efficiently to solve the problem. The other one, of course, is appropriate intervention for the particular condition that is being managed. That's also very important. In fact, that also includes drug management, because with medications, in some instances, you can actually change the course of a disease. Like, we manage some patients with chronic inflammatory demyelinating polyneuropathy, and steroid is not that expensive. We were able to make the right diagnosis, and we were able to reverse the disability, of course, with physiotherapy and other support. So making the right diagnosis is always very important. So that's very important. Then, very, very importantly, is that for low-cost rehabilitation, you have to deploy the right tools to really make a change. Now, one of the things we do, because we know that many patients cannot afford to stay in hospital for a long while, is that while they are in hospital, we train them what they might be able to do by the time they get home. We also try to train the caregivers what they are going to be able to do for the patient when they get home. So we call this task sharing. There is also task shifting, which might be to the extreme, because the caregiver is already overburdened and overwhelmed by the caregiver burden. Then adding a lot of other tasks may make it more difficult for them to do the right thing. But we can do what is called task sharing, by teaching them some of the simple things they can do for the patient, and the patient can do for him or herself, to increase the intensity and duration of practice, which eventually increases independence in performance of activities of daily living. So these are some of the things that we've done. And of course, we also try to train people to spread this information. We've tried to generate a lot of enthusiasm in both students as well as practitioners across the region. Last year, we organized the first workshop and, of course, also the first conference, and it was well attended. In fact, we had to live stream using CCTV, closed circuit TV. A lot of students wanted to come. We were able to take only a certain number. So there's really a lot of enthusiasm, in spite of the fact that there is lack of resources. The number of neurologists in the country is just a little bit over 100, a country with 180 million people. Very, very few speech therapists, maybe only about 10 in the entire country, and very, very few occupational therapists. Of course, physiotherapists, we have quite a number of them. So, but we're bringing all these together, and we're also trying to develop training programs to make sure that the right things are done. So these are some of the principles we've been And then integrated care, extremely important that rehabilitation is delivered within the continuum of care or integrated care. I will explain that and illustrate with stroke. Stroke care revolves around 4 major pillars. First of all is generating evidence, epidemiologic surveillance, to know what the burden of stroke is, which is going to inform policy and practice. Then it's primary and secondary prevention, which is extremely important because even in stroke patients, you really still want to prevent complications. You want to prevent them from having another stroke, apart from helping them to recover and regain function, from the stroke they've already had. Of course, acute care is also very, very important. If you give the right acute care and acute care at the right time, you are able to reduce the severity of disability, and therefore your intervention would work more rapidly, and hospital stay is shortened, recovery is faster, and therefore resources expended is also minimized. Then, of course, is rehabilitation, which is the 4th pillar.